Okay, so today's topic is heart failure. Let me see. There we go. Heart failure, I've divided my lecture into these subtopics. First of all, the general definition. Then we'll be talking about different ways to classify heart failure. We will continue with the pathophysiology of heart failure to classical clinical presentations that are relevant with physical exam findings, lab findings, chest x-ray, and then how do we treat heart failure? So the pharmacology aspect. And then we'll have a question and discussion round afterwards. Okay, second. Okay, the definition of heart failure is, heart failure describes all situations when the heart is insufficient at maintaining adequate circulation. There are many ways to classify heart failure. The first way to classify heart failure is symptomatic, and a very common tool here is the New York Heart Association classification, generally called as NYHA. Then we classify heart failure into right, left, and global heart failure, compensated versus decompensated. And then a more scientific approach with the echo is looks at ejection fraction of the left ventricle, and they differentiate between preserved and reduced ejection fraction. And this can be understood as systolic versus diastolic heart failure. And I'll get into each of these points now. So let me start with symptomatic heart failure. So I found this on the internet, and the sentences below each moving heart have the typical description of heart failure. But at the end of the day, for clinical exams and for when we're in the hospitals, we need to just have a few words in our head that somebody's not muted.
Please mute your mic.
Dr. Conrad, if you can mute everyone, please proceed with it.
Yes, I think I muted someone. So
Yes, you can do that. You can.
Okay, so yeah, so these are the four classes of symptomatic heart failure. The first class, I could just call it a scientific heart failure because it doesn't present with any symptoms and the normal patient going about their normal lives. Here it says no limitation of physical activity. Ordinary physical activity does not cause symptoms. So this is not immediately clinically relevant for any acute decompensation or anything. So we'll call this scientific heart failure. And then there's class 2, class 3, and class 4. These are the people that we can see heart failure in. The weakest heart failure, class 2, that we can clinically see is when somebody has dyspnea and has trouble breathing after climbing 2 flights of stairs. So we categorize this as a slight limitation of physical activity. So it takes them 2 flights of stairs to have trouble breathing. And then it can progress to a bit worse, and then they'll already have trouble breathing after only 1 flight of stairs. And eventually the highest classification, the worst, is class 4. And this is when they just have trouble breathing when they're sitting. So at rest. So to use this classification, symptomatic classification of heart failure, we'll just remember class 1, scientific, class 2, 2 flights of stairs, trouble breathing, class 3, 1 flight of stairs, trouble breathing, class 4, at rest, trouble breathing. Let me move on to right versus left versus global heart failure. So can you see my arrow?
Yes, we can appreciate it.
Okay, perfect. So RHF means right heart failure, LHF is left heart failure. So right heart failure is when the right ventricle is not working efficiently, and right heart failure is the characteristics of right heart failure are congestion and backflow. So we will see this in problems with the liver, the kidneys, and the classical presentation of edema in the lower extremity, so pretibial edema. Left heart failure, on the other hand, because right heart, lungs, left heart, will congest back into the lungs. So that is why we will have pulmonary edema. And left heart failure is also a big part of left heart failure is the forward failure of the heart. So the insufficiency of the heart to expel blood into the periphery and to the organs after the heart. So one of the main organs that we have to watch here are the kidneys. When the kidneys are hypoperfused, this can lead to kidney failure chronically and acutely. Lastly, periphery as in muscles and other organs. And so when we combine these two, then we can have a presentation of global heart failure. And the way to approach global heart failure is best to, first of all, think of left heart failure. And this is also the most classical way of it evolving over time. If we have left heart failure, which I already showed you here, it congests back into the lungs, leading to pulmonary edema. This pulmonary edema can result in trouble for the right heart because of the increased resistance in the lungs, and eventually weakening the right heart, leading to right heart failure. So we have left heart failure that resulted in congestion in the lungs, which resulted in right heart failure. So global heart failure is basically a combination of everything. If we just this plus this, then we get global heart failure, this big chain that has everything in it. Okay, so the next classification is, often words used in the clinic, is compensated versus decompensated heart failure. So when our heart starts to fail, we have physiologic mechanisms that compensate for this heart failure by increasing the heart rate and blood volume. Again, heart failure was the insufficiency of the heart to supply organs downstream, and we can enhance or better this by creating more blood so that there's more in the periphery, or by increasing the heart rate. And if this isn't working anymore, we can help our body with medicine, so pharmacologic compensation. And when both of these mechanisms of compensation fail, the physiologic compensation and the pharmacologic compensation, then we have decompensated heart failure. So when these fail and there's an acute symptomatic decline, it is termed decompensated. And this is often what requires treatments in emergency departments. And the main complaint that patients with decompensated heart failure have is dyspnea. The next classification of heart failure is best explained with math. So there's, and it is categorized with the help of an echo. And it's in the science papers and all, they use a preserved and reduced ejection fraction. And this can be the synonym of this can be systolic heart failure and diastolic heart failure. So first of all, we'll look at the classical and most easily understood part of it, which is the one with the reduced ejection fraction, which is defined as under 40% ejection of the left ventricle volume. And this can be also called systolic heart failure. So I wrote here, the heart muscle is not functioning appropriately, and the ejected volume is too little, oftentimes due to contractility issues. So the math example, to have a picture of this, I always picture it with cups that are full of water, and the cups in the water don't mess and aren't good enough. So let's look at this calculation here. So my body, the body needs 100 milliliters of blood, and the end volume of my left ventricle is 200 milliliters. But if my heart is weak, it won't eject 100 milliliters, it'll only eject 70 milliliters. So this is 35% of the 200 milliliters. And 70 milliliters is 30 milliliters less than 100 milliliters that I need. So I have too little, and this is heart failure. So I have heart failure because I ejected 30 milliliters too little. This is reduced ejection fraction. This is systolic heart failure. On the other hand, I can have diastolic heart failure, or heart failure with preserved ejection fraction, which means that the heart is capable of ejecting 50% of its volume. So the heart muscle is functioning appropriately. However, because of reduced capacity, which is the end diastolic volume, the output is too little. So in my math example here, we still need 100 milliliters of blood, but the left ventricle, instead of holding 200 milliliters as it should, it can only hold 150 milliliters. And it ejects 60%, which is healthy, which is good. We have good contractility. But in this case, the 60% of the 150 are 90 milliliters. And that's 10 milliliters below the 100 milliliters. So even though the ventricle is working appropriately and the ejection fraction is preserved over 50%, it is 60%, we have a deficiency in the periphery. We have 10 milliliters too little. So this is diastolic heart failure because the end diastolic volume is too little. But we have preserved ejection fraction, so it is called preserved heart failure with preserved ejection fraction. If there are any questions about this, we can talk about this later too, again. Okay, so this I put in, this is a wild slide. This I just put in so that because I'll share the slides with you later and you can look at this in more detail, but I just thought it should be in there, but I'm not gonna go into it in depth right now, but this is just, so if you go back and you can look at it, then you'll have this overview. So the fundamentals of the pathophysiology are two principles. So if we have decreased cardiac output, our body compensates this by increasing heart rate. So if this were the only case, if we had decreased cardiac output, we just increase our heart rate, then everything's fine, then we wouldn't have heart failure. Heart failure is because of what happens next. So that's what I wrote here. In the long run, it is potentially harmful, this increase of heart rate, because increased heart rate is accompanied by a shorter diastole. And the heart muscle itself is perfused in the diastole. And if our diastole is too short, there's too little time for the heart muscle to be efficiently perfused and nourished. So we have suboptimal cardiac muscle perfusion. And this leads to chronic cardiac muscle injury. And this leads to reduced contractility, reduced stroke volume, and reduced cardiac output. So this is how, by helping our original problem of decreased cardiac output with an increase of heart rate, we, years down the line, reduce our cardiac output again. And this is a vicious cycle, and this is heart failure. The heart failed in compensating. Later on, we'll come full circle and talk about beta blockers, which are classic medicine. And the beta blockers address this exact issue because they slow heart rate and lengthen diastole, which means that they hinder the cardiac muscle suboptimal perfusion. So beta blockers address this mechanism of heart failure. The next fundamental physiology that needs to be understood when talking about heart failure is the decreased renal perfusion activating the RAS system, the renin, angiotensin, aldosterone system. So when the kidneys are hypoperfused, they do not get enough blood, as is the case in heart failure, as I showed earlier with left ventricular heart failure. Kidney was my next little block. What happens? Two things happen. Angiotensin is released. This causes vasoconstriction, vasoconstriction increases the afterload of the heart. So if the vessels get tinier, it's harder for the heart to pump the blood into these tinier vessels. This increases the energy the heart needs and increases myocardial oxygen needs. And eventually this leads to myocardial impairment because these needs are not met. This then leads to decreased stroke volume and cardiac output. The second thing that the kidneys, the ROS system and the kidneys do when they are hypoperfused is aldosterone is released as a result of angiotensin within the ROS system. Aldosterone increases salt water resorption. This is good in the beginning because heart failure, again, meant we have insufficient supply of the periphery. And by increasing blood volume, it's like it's hacking the system. We're just making more blood, so then it's easier to put blood everywhere if we have more of it. So by increasing saltwater resorption, we're creating more blood volume, but the bad side, the negative side of this is that it also increases the preload on the heart. So this is the heart, and there's a lot of volume in front of the heart that is just waiting to be moved on by the heart. And if there's too much saltwater resorption, too much volume, then this can be too much for the heart to efficiently move on. And so we have a backflow. We have big backflow, and this is when we have edema. Okay, so the ROS system and its activation are in the beginning good, just like in the beginning the increase of heart rate was good too, but down the line it can lead to problems. We address the activation, the overactivation or the activation of the ROS system in heart failure by implementing ACE inhibitors, angiotensin receptor 1 receptor blockers, aldosterone antagonists, diuretics for the edema, and angiotensin receptor neprilysin inhibitors. I don't know if I pronounced that right, but ARNIs for short. Yes, so the next slide, what happens in heart failure, this is a graphical demonstration of this. We can see heart failure, as I've been mentioning, reduced cardiac output, volume overload, decreased kidney perfusion, saltwater retention, increased preload and afterload, which makes it, the heart has to work even more, but the heart is weak. So the heart is stretched, myocardial stretch. I'll get into this later too. It releases ANP and BNP. ANP and BNP are basically the opposite of aldosterone. Instead of saltwater retention, aldosterone does this. BNP, ANP, they do saltwater excretion. This decreases preload. So usually these systems are in balance. The lines would be equally thick. But in heart failure, this is not strong enough to counter this. So when this outweighs the bottom, we have heart failure. So another fundamental way to think about heart failure is how does it integrate into shock? And this is the formula that I don't know if you can see it completely because of my screen. There we go. So, okay, let me see here. Okay, so the formula for shock that has a lot of things in it and that make shock easy to understand and know what is easy to do, but maybe somebody else would get into this in a shock lecture, is the following. This is the mean arterial pressure equals cardiac output times systemic vascular resistance. Cardiac output is a combination of heart rate and stroke volume, and stroke volume is a combination of preload and contractility. So what happens in cardiogenic shock is that there's something wrong here, and in the case of heart failure, it is there's various heart failure can have an effect on many of these things, but mostly on contractility because of chronic heart remodeling and heart damage. So because heart failure affects this side of the equation, you can see how it can play into shock. And in the worst case, for example, acute decompensated heart failure, we can have cardiogenic shock. I just wanted to put this in here so that it's, if you go back and review these slides later, it can fit into a bigger system and appears logical, which makes it easy to understand. Okay. Okay, so let's now the clinical important things. So what happens when somebody comes in? What do they have? They're going to say, oh, I'm tired. So they're going to have reduced exertional capacity. They're going to say, I used to be able to run a mile or 10 kilometers, but now I can only run 3 kilometers. Well, actually, it's older people, so they're not running anymore. But they'll be like, I used to be able to work in the yard for 10, let's say 3 hours in the afternoon. I used to be able to cut my roses or tend to my plants or tend to my crops, to my whatever. And now I can't do that anymore because after an hour, I feel like, oh, just short of breath. So they have reduced exertional capacity. And then their pulse will also be high. We talked about this earlier, how the increased heart rate is a mechanism of compensating for decreased cardiac output. So increased heart rate is a characteristic feature. Then I tried to classify, or I tried to put the symptoms with what kind of heart failure they are, just for understanding purposes. So if we look at this, where's my mouse? Right heart failure. We said that because of the backlog and the congestion downward into the vena cava, into the liver, and then eventually into the legs, we can have lower extremity edema. So classic presentation, they have edema that you can really put your fingers in and then you'll leave a indentation that'll take a while to resurface. Because of this lower extremity edema, patients are walking around all day, so the salt water collects in their legs. And then at night, when they lay down in bed, the water in the legs and the edema, it just flows back into the body and flows back to the heart and to the kidneys, and then they have to pee. So that is why they have to go to the bathroom at night. So classic presentation, a classic heart failure patient has nicturia. They have to get up in the middle of the night to go to the bathroom maybe 2 or 3 times because the edemas that collected during the day are being washed out at night. I said before it goes into the edema, you can also sometimes collect in the liver. This will lead to hepatomegaly by venous congestion, classic right heart failure symptom. This one is left heart failure and right heart failure. And this to me is very important because it's a double punch to the kidneys, and kidneys are a very important organ. So first of all, because of left heart failure, they can be hypoperfused. And because of right heart failure, the blood can be congested and backlogged into the kidneys. So there's no blood coming in, and there's blood that has all its nutrients have already been extracted, all the oxygen has already been extracted, is clogging the kidneys. So we have a double punch kidney failure from left heart failure and right heart failure, both leading to kidney failure. So the kidneys are very susceptible and very in big danger in heart failure. Another symptom they can be confused, and this can have various reasons, but for example, in left heart failure, they can have cerebral hypoperfusion. So if somebody's confused and has edema, think of heart failure. And then one of the most classic presentations next to the lower extremity edema, which are from right heart failure, are the intra-alveolar pulmonary edema from left heart failure. This can result in dyspnea, which is in line with reduced exertional capacity, and orthopnea. Sometimes my pronunciation is a bit off. Orthopnea is when you have to sit upright so that you can breathe well. That is why the patients sometimes when they go to bed, they're lying down and they can't breathe, and then they have asthma cardiale, which is cardiogenic asthma because they have to cough at night, and because they're having trouble breathing because of all this pulmonary edema. So they have a cough at night, and then to counteract this or help this orthopnea, they put pillows under their heads. So sometimes heart failure patients will have 2 to 3 pillows, and they'll not be sleeping flat, but they'll be sleeping like this. For the people who have, for the people who already know about nephrotic syndrome, that's a classic differentiation. In nephrotic syndrome, you have edema in the eyes and kind of right here over the eyes, and this is because the people with nephrotic syndrome can sleep flat, but the people with heart failure, they can't sleep flat because of the pulmonary edema, so they don't have edema in the eyes. That's just a fun explanation. But yeah, so left heart failure can lead to pulmonary edema, cyanosis, dyspnea, asthma cardiale, all these breathing difficulties. Let's keep moving. Physical exam findings that you can see: inspection, orthopnea, dyspnea. They're not going to lie down in their bed in the hospital. They're going to have the back of the bed, as I mentioned, already upright. They're going to have an elevated jugular venous pressure. So you can see this if you ask the patient to look to one side, and they're lying in bed, the JVP won't be here, but it'll be all the way up, so you might be able to really see their neck veins. Palpation, when we palpate the apex of their heart, because the heart enlarges in heart failure, will be laterally displaced. Usually it's in the midclavicular line, and it can be much further laterally. They can have a big liver, so hepatomegaly. They will have lower extremity edema, and their pulse will not be, it could be just not regular, but it can be, it'll usually be regular, but it will be of different intensity because the ejection fraction is inconsistent, sometimes a little more, sometimes a little less. So we call that pulsus alternans, alternating pulse characteristics. And then when we listen to the heart with our stethoscope, for the lungs, we will hear this pulmonary edema that I was talking about. We will hear bibasillary inspiratory crackles. And heart sounds, very sometimes hard to hear, but we'll have a third heart sound, S3, which is after the second heart sound, and which happens when the ventricles are pretty full because of reduced ejection fraction. So then in the chest X-ray, a classical finding, also oftentimes asked in tests, is the heart-thorax relationship. So in a chest X-ray, the heart will be wider than half of the chest. You'll see enhanced vasculature and a pleural effusion. It starts on the right side. It's also sometimes a classic exam question because the pleural space has a more negative pressure on the right side. So that's why if it's a regular pulmonary edema because of heart failure, it'll sometimes collect on the right side first. Okay, the labs. You can't give a presentation or a lecture on heart failure and not mention the BNP, NT-proBNP, which is what we measure in labs. It's basically the D-dimers of heart failure. D-dimers are a test for a pulmonary embolism or deep vein thrombosis. And what we use it for in deep vein thrombosis is, here I say I have a negative prognostic or predictive value. So if we suspect deep vein thrombosis in the legs and we measure the dimers and the D-dimers are negative, then it's ruling out. If they're positive, it could be, but if they're negative, it's ruled out. So if we think somebody has heart failure and they're having trouble breathing and everything, and we measure the NT-proBNP, and we can't measure any elevation of it, then we have to think about other causes of this trouble labored breathing. And if they're elevated, heart failure is likely, but it doesn't have to be heart failure. But if it's negative, no NT-proBNP, probably very likely a different cause for the So proBNP, a high negative prognostic value. It can be elevated in kidney failure. That's why you always have to think about it. But what does BNP do? I should have mentioned this earlier. It's a natriuretic peptide. So it initiates saliresis, salt water out the kidneys to decrease the blood volume and relieve the heart. So BNP is something that the heart excretes to help itself. It's its own compensation mechanism. And BNP is eliminated by neprilyzine. And that is why in the pharmacology tie-in is neprilyzine inhibitors. So if we inhibit neprilyzine, we'll have more BNP, which means we'll have more saliresis, which means we'll relieve the heart by reducing the volume. So any heart that is stretched too much by too much volume, then we have BNP, and we can measure this in a lab test. Another important thing that you have to look out for during heart failure, especially treated heart failure, are the electrolytes. So if somebody is confused and has heart failure, think about sodium, because low sodium can lead to confusion. And people who have heart failure tend to have low sodium, and is also very predictive of prognosis. Somebody that has too low sodium has a very poor prognosis and will have has a high very soon death rate. So low sodium is very bad in heart failure. And if somebody's on diuretics as treatment for heart failure, always watch their potassium. So if somebody has weak muscles and is having trouble getting up, then look at their potassium. It might be low. Okay, so the classical patient, history-wise, who presents with heart failure is going to have had hypertension 10, 15 years ago. Because of the vessel remodeling that occurs with hypertension, this patient will have a myocardial infarction at some point. And then because of the scarring of the myocardium, they will have a contractility issue, and this can lead to chronic heart failure. So that is a classic presentation and involvement of a patient in your care. So the pharmacology, every country probably has different guidelines, so I just kept it to the basics, and I tied it into the classifications. So remember, this stands for the classification, the symptomatic classifications. 1 was the scientific one. 2, they can climb 2 flights of stairs. 3, only 1 flight of stairs. And 4, they already have trouble breathing at rest. They all get ACE inhibitors or sartans. So anybody who has heart failure, symptomatic stages 1, 2, 3, and 4 are all on ACE inhibitors. If they can't tolerate ACE inhibitors because of the cough or because of any other issue, then they might be switched to a sartan. And starting at level 2, NYHA level 2 to 4, all patients are on beta blockers and aldosterone antagonists. So somebody who has heart failure, stadium 2, is going to be on ACE inhibitor, beta blocker, and aldosterone antagonists. This is because beta blockers and RAS system drugs, so the ACE inhibitors, aldosterone antagonists, they better the prognosis. These are the only medications that better the prognosis. All other medications, so diuretics, digitalis, glycosides, they decrease hospitalization rates, but they have no significant effect on the prognosis. So you would give somebody diuretics in acute decompensation if they're having really a hard time breathing because of pulmonary edema, and if they're overloaded, so they have all this leg edema, you'll give them diuretics to flush them out and quickly help them out and get the water out of their lungs. And I put this in digitalis, the heart glycosides. They're kind of out of fashion for heart failure, and they're used more in atrial fibrillation now. But some patients still require these. They enhance contractility, but they are not the state-of-the-art treatment anymore. Okay, so that would be the end of my presentation. I put in some review questions in case there are no questions for learning purposes. And if you go back and review these slides, and these are just a few questions to test your understanding, and you can orientate yourselves by those questions when you review the material. But that's the end of my lecture, and I look forward to the discussion and the questions. And